So good afternoon, everyone. You're welcome to QPS TalkTime. This is our 26th episode and our last episode of this season. We'll be taking a summer break, like I hope many of you will. And we've kept, I think, some of the best to last. So today we're going to talk about clinical audit and really focus on audit and action. And I think it's very timely. This is the Audit Awareness Week, Clinical Audit Awareness Week, which has been marked in Ireland and across the UK. And the theme of this year's Awareness Week is local focus and global impact. So I think we're going to see lots of examples of that today. So you can follow us on social media, and we're in lots of places now. We're on X, formerly known as Twitter, today. So please do tag us and put up your own thoughts and comments on the session. If you don't get to watch the whole of today's session, you can watch it back later on the NQPS YouTube channel, and you can see all of our previous episodes are up there, and we've had lots of great guests over this season and previous seasons, and they're all available. And we're also on LinkedIn now, so you can follow us there and pick up some communications from us on LinkedIn as well. Just a flag, for the Sepsis Summit, which is going to be on in September, on the 3rd of September in Dublin Castle. And there's a call for abstracts out now, so we would encourage people to submit their abstracts. Really, anything around sepsis, I think, would be welcome. And the abstracts are open until the 19th of July. So please put your abstracts in, and you can follow the QR code there to link you to the abstract site. So, like I said, this is Clinical Audit Awareness Week. So we're going to focus on the importance of clinical audit. We're going to hear from colleagues, and there's a large partnership of people across the health services. So HSE, and there's lots of abbreviations here. We're going to put some links into the chat for people to, if they want to check out, what some of these groups are and learn a little bit more about them. So we have the HSE National Centre for Clinical Audit, NCCA, we've NOCA, the National Office for Clinical Audit, NPEC, the National Perinatal Epidemiology Centre, and the RCPI with the National Specialty Quality Improvement Programs there. So everybody here is collaborating and working together on audit, and we're going to hear about the 2024 staff clinical audit survey today. We're going to explore the effectiveness of national and clinical audits within local healthcare settings, focusing especially on quality improvement and implementation, so moving from audit to action, and looking at some of the enabling features and challenges of that. Going to talk about findings which help to identify areas for improvement in clinical audit process itself, and then explore how to use the findings to inform action plans and make improvements in the HSE to support and build a culture of QI across and close the clinical audit cycle. And to help us do all that, we have a great panel of speakers. So I'd like to welcome everybody to the session. So Dr. Angela Byrne is a Paediatric Radiologist at CHI Crumlin, and she is also the National Specialty Lead in the Specialty Quality Improvement Program for Radiology at RCPI. Professor Conor O'Keane is a consultant pathologist and is the clinical lead for quality improvement at NOCA. It's a pleasure to welcome Dr. Colm Henry, our Chief Clinical Officer in the HSE. Karen Reynolds is a Senior Manager in the HSE National Centre for Clinical Audit with the NQPS, and Edel Manning is Program Manager with the NPEC program. So you're all very welcome, folks, and I'm going to call on Colm just to welcome everybody. And Colm, I know you have another engagement, but I think it's a pleasure to welcome you here on Clinical Audit Awareness Week to remind everybody of the importance of clinical audit.
So look, thank you, and it's the honour of asking me here and to share this panel with such esteemed people. You ask a question, what does audit mean? Certainly, to me, it's about leaving a legacy, about leaving something better than how you found it, and it's a continuous process. So people here engage with audit know that it's about continuous improvement, an endless kind of restlessness to never settle on what you on services or the way we deliver care, but to constantly strive for improvement, and as I said, to leave services in a better way than how we found them. So it's a really important thing, I think, for all clinical leaders, because so much of our time is spent in the reactive space, and the reactive space gives no time and allows no time to build capacity. And the truth is, of course, the more time we invest in the proactive space, a bit like healthcare prevention or illness prevention, healthcare promotion, the more time we spend with that, the less time we'll have to deal in the reactive space, because we'll have a stronger, more resilient delivery system. So just, I know we're meeting John during Clinical Audit Awareness Week, which takes place on Monday, 24th of June to Friday. It's an opportunity for everybody to learn about clinical audit and how to undertake audit in our services. The theme this year, I understand, is local focus, global impact, celebrating Clinical Audit Awareness Week 24. And we're working, as you said, John, with the National Office of Clinical Audit, lots of acronyms here: NOCA, the Royal College of Physicians, National Perinatal Epidemiology Centre, of course, NOCA. And today's talk time, Clinical Audit to Action, is about transforming data into quality improvement. And we hear from colleagues from the NCCA, NOCA, NPEC and the RCPI about this staff audit survey, which is carried out in 2024. And the purpose of the survey is to assess the effectiveness of national local audits within local healthcare settings, focusing on the quality improvement as the implementation, enablers and challenges, and help to identify areas for improvement in clinical audit processes. I'm looking forward to hearing from my esteemed panelists as they discuss findings that will help identify areas for improvement in clinical audit processes, and how we can use these findings to form an action plan for us in the HSE to support and build a culture of QI and close the audit cycle. And it's timely, John and colleagues, that we're doing this now, because we're in the middle of reforming the whole QPS entity and centrally, and designing it for the regions. And I've been in close contact with the REOs, all 6 of whom are appointed in position now. And what's really key to them is setting up integrated QPS structures in each of the regions. But what's equally important to them is that these structures are not focused on that reactive part of the cycle, but are focused on capacity building, on audit and quality improvement. And we need evangelists and advocates like yourself, like Conor and others, to bring that message to REOs, because if nothing else is done, they will find themselves in that reactive space all the time. And I know from talking to them in my engagements today, they're very enthusiastic, really enthusiastic about the concept of clinical teams, or the concept of building capability within teams, within units, within divisions, within hospitals, within community, to build a culture of quality improvement. And we know that those governance structures I refer to are going to be really important at local, regional and national levels. And as I said, this will be captured very strongly within that regional clinical design of QPS. We will have reporting lines through to regional clinical directors, and we ensure that those existing QPS structures and those quality improvement teams, that we want to harness as much of their work as possible in these new structures. People will be aware of the Patient Safety Act, will soon be implemented, and it seeks to provide protections for staff, health service organisations who are undertaking clinical audit in line with best practice. And all of this helps to support and enable a culture for audit. And the survey I referred to shows we need to do more to close the loop for clinical audit and use quality and safety resources and personnel to support QI at all levels in the organisation, something that Conor has been going on about for a long time. And you'll be reminded of course, during these sessions, of the resources and training that are currently available to you from the NCCA and then QPST. So I'm looking forward to this session, and I hope everybody finds it enjoyable and informative.
Thank you so much, Colm, and thank you for being here. I love that idea of leaving the world better off, than you found it, and There's a lovely quote I heard once from, I think, Jonas Salk, I think, who discovered one of the polio vaccines, that he said the most important thing in life we have to do is be good ancestors, you know, to leave the world in a better way. So I think that's a lovely springboard into what we're going to hear about clinical audit. And I'm going to get Karen maybe just to start telling us a little bit about that, and maybe a little bit about the survey and what we've learned from the survey. And over to you, Karen.
Great. Thank you, John, and thank you, Colm. So a warm welcome to everybody, and thank you all for joining us this lunchtime. We're delighted to have you on board and to share with you the findings from this year's Clinical Audit to Action survey, which was an electronic survey done the last 2 weeks of May of this year. So the title of our survey was Transforming Data into QI. So we're going to share the results with you right now. So just to acknowledge that this survey was done in partnership with our colleagues from NOCA, National Office of Clinical Audit, NPEC, and our colleagues from RCPI. So Professor Conor O'Kane is going to share with you the national clinical audit results that came from the survey. And on behalf of the HSE National Centre for Clinical Audit, I will share with you the local clinical audit results findings. So the responses, we did 150 responses to our survey. So this survey provides a snapshot of, I suppose, feedback, which is so precious to us on the ground. And this feedback, we take it on board, and it assists us then in the planning of our programme into the latter part of this year and into future planning. So as you can see there from the geographical spread, we've been delighted that we've had engagement from right across the jurisdictions, and we will delve into that now in further detail as we go through the slides. So I'll hand back there to John, who will introduce Conor.
Thank you, Karen. And yeah, it's a pleasure to welcome Conor to QPS TalkTime. Conor, I'm going to hand over to you to tell us about the national findings of the survey.
Thank you, John. Good afternoon, everyone. As is appropriate in QI, I'm only speaking to data, which is what we all try to do, although I do have lots of opinion, which you may hear about later. So 1/3 of those who surveyed were directly involved in national audit, which is again encouraging that it's a relatively diverse group. You'll note that there was 150 responses, and some of you might say that's a small number. That's only 20% of all the people attending the conference today, but you don't need to be reminded that for QI, small samples are more than adequate, and 15, 20 is sufficient for any of your projects. So these are useful findings. Most people were very familiar with what was involved in audit and were very happy with clarity of reports, which is good. Timeliness was a concern, and of course this is always a concern, and so particularly for NOCA with national audits, there is always going to be a timeline. But for everybody doing local audit, as you know, PDSA cycles can be run over a time period of 1 to 2 weeks. There's no unit that can't do a QI cycle and develop a 20-person sample over 2 weeks, which allows them to do the work. So we do recognize that timeliness is an issue, but it's not an issue for local audit. It's certainly an issue for national audit, and something of which we're aware. People again were very encouraging in terms of discussion of audit results. The vast majority of people had discussed audit with their team or department, and most were confident that the audit was leading to an improvement in clinical care and activities of that department or unit. Less encouraging perhaps is the left box, which shows that discussion with management is less than that which occurs intradepartmentally. And that highlights one of the challenges in QI in every control phase is making sure that senior management are directly involved. It's very encouraging to hear Dr. Henry say this is a priority for the regional organizations. It's essential that these organizations work in this framework, and the data here shows that there is a gap and an opportunity for improvement. And again, the data is being used highly appropriately for quality improvement, for assurance. And then this is an important question: how much data do you need for assurance and how much for improvement? And sometimes it can be both, but at a certain point it's important to know exactly what you're doing, what you're collecting that data for. And then there's a very comprehensive and encouraging list of improvements in services and departments as a result, which will be visible on these slides when circulated later. And it just means that there is quality improvement occurring right across the system, and it's wonderful that people are getting into this space. The numbers attending this webinar confirmation of that, and keep up the good work. And these are things that you thought would help. And obviously there's the issue of resources. Now, I would remind everybody that education and training is also important. Dr. Fitzsimons has mentioned the importance of the resources available on QPS. And I think, again, a very good topic, which I know many of you do, is to tackle these in teams. So do the one-day introduction, do the 3-day course, do it as teams of 3 or 4, and it becomes a fantastic positive learning exercise, and you teach each other. And then the process and management, there is access to data. I think we have most of the data we need locally to do most of the improvement that we need to do. And a final point on resources and staffing. Many people brought up the issue of resources and staffing. I would remind you of the QI mantra that we come to work every day to do 2 things, to do our job and to improve things. So it's up to us to carve out that space. And if I'll allow a personal plea that I know Dr. Fitzsimons will get cross with me to say, you know, we can lean out our processes. 80% of what we do is waste. Any of your improvement processes in the first instance should focus on safety. And I think that's very important. After that, take the waste out of the system. And then there'll be lots of time to do improvement. Thank you very much. Thank
you for that overview of the national aspects of the survey. And thank you as ever for your enthusiasm and lots of things for us to think about. And we'll come back and talk about them in the panel in a few moments. I'm going to hand back to Karen, who's going to maybe focus on the local aspects of clinical audit from the survey.
Great, thank you, John. So we're going to share with you now the findings from the respondents with regard to local clinical audit. So as you can see here, as Conor mentioned, there is overlap because we acknowledge that many people at service levels are involved in both some of the current portfolio of national clinical audits and indeed then a broad range of the local audit activity taking place right across the multidisciplinary teams. So 143 of our responses here would categorise themselves as having experience in local clinical audit, and the breakdown pretty much 70% hospital-based and great and encouraging to see 30% community-based. So we've got a nice mix right across the 30% of respondents there, ranging from primary care, mental health services, older people services and disabilities. So we're just deep dive in here to some of the actual questions and the findings. So in terms of the results of local clinical audits, we asked people in terms of, are the results of local clinical audits conducted within your setting shared with your governance structure? So this would include perhaps your local QPS committee, your local clinical audit committee for the bigger centres, and indeed your local or executive management team. So again, the results here are encouraging, with 40% always sharing, 38% sometimes, and then we have sort of on the right-hand side of the graph, averaging out of 25% of where there's room for improvement. So we'll come back to that locally when we move to the QI space. So then we ask people, in your experience, how effective are local clinical audits in identifying areas for QI within your healthcare setting? So again, the results here are encouraging, with a lot of people saying very effective and some people saying effective. And again, similar findings at 25% of where there's room for improvement there. So we're going to talk about that in greater detail on the panel. So this is really moving into stage 6 of the clinical audit cycle, which is the development of a QI plan and indeed a related action plan. So we ask people here, while conducting a local clinical audit, is stage 6, which is the QI piece and the action piece of the clinical audit cycle, completed? So again, there's significant room for improvement here, because we do recognise that this is the challenge of joining the dots with clinical audit and indeed the related challenge of closing that loop. So we had 56% of respondents saying that sometimes that happens, and then averaging out at 22% in terms of room for improvement there. So related to that is the importance of developing, as we say, a quality improvement plan and action plan on the basis of the audit. And again, in the spirit of good QI and moving to that space, it is essential to monitor the outcomes of that audit through monitoring the timelines arising from the quality improvement plan. So that is something there that sometimes happens in spaces, but as we know, it is a challenge for lots of different reasons. And I know we're going to delve into that on some of the panel discussion in a few moments. So this is the final graph here in the local section. So the issue of time and time for clinical audit is real, because again, there aren't enough hours in the day, in the week, And we know people are so committed with their clinical practice. But what we do know is that there is a lot of enthusiasm and people are currently making time for clinical audit. So obviously we'd like to see that move in terms of the feedback there for ring-fence dedicated time. So that is something I know that is, certainly at discussion stage across the jurisdiction. And then finally, we've asked people, does your service department have an annual audit plan? So like all good practice, it is good to future plan. So this is something, it can be a very powerful thing to do. It is setting out, as Colm related to earlier, it's been proactive. It's not waiting to be reactive. So it's setting out what should be the topics that you should be auditing related to your service. So certainly we have got lots of resources and lots of tools that we can assist you with, and we'll have a look at them in a later slide. So finally, we similarly ask people, what are the improvements that are seen as a result of local clinical audit? So lots of themes coming through here, and I suppose, which is very encouraging, that clinical audit does, and we know this from the international literature, it certainly leads to better patient outcomes. It enhances patient safety, and certainly from the findings here, we're seeing a lot of developments with improvements in patient pathways. We're seeing strong interest and delivery of training and education for clinical audit, and lots of related initiatives coming out of that. So that's really encouraging. So finally, we ask people, what can help to ensure that QI happens during the clinical audit cycle at local level? So again, we got lots of feedback here, and everything is themed and grouped. So again, it's hard to single out one item over the other, but perhaps on the bottom right there, and again, I think it's testament to see all of the support for clinical audit here today, both from having everybody present with us. So that whole ethos of having the support from our senior leadership right through the teams, that leadership and oversight is key. And with that comes the built-in accountability and follow-up. I think it's fair to say that everybody on the call here is an advocate, not just of clinical audit, but also of QI, and knowing that when used correctly, that clinical audit is and can be a very powerful tool that will lead to continuous improvement. So we're going to look at lots of examples of that now in the panel feedback. Just to acknowledge everybody, thank you again for being part of the survey. And I'd also like to say a special thank you to our colleagues in NOCA for the data analysts and for the collation of the slides today. Thank you.
Thanks, Karen. That's great. And it was great from yourself and Conor to get the overview of that survey, and lots of really useful information in there. And I think I'm going to invite our panel to come together. So Conor and Karen, you're joining us, and along with you, we've got Angela and Edel as well, who are going to join. And I think if Colm is still there, I'd encourage him, if he wants to join in at any stage, please do. I might just start with a couple of questions then for our panel, and I think Juanita's going to look for questions in the chat from our audience. So again, we'd encourage people to put their questions in there. But Karen, I might start with you. You were telling us there that about 75% of cases result in the clinical audit information been shared with local governance structures. Why is that important? Why is it important that we share what we've learned from audit?
Yes, so as we saw there from the feedback, certainly it is essential to share, because by sharing, that brings the wider multidisciplinary team on board. It's also important that when we go back to the theory of clinical audit, which is always important because it keeps us focused. So that last stage, stage 6 of the clinical audit cycle, is actually the QI part. So to move to that part, it is essential to join the dots. So yes, it's great to have the audit done. It's wonderful to have your audit report, but it is of equal importance, if not the most important, to produce your related quality improvement plan and action plan on the back of that. So by bringing and sharing those results to your local, in the case of local level, that could be your local or executive quality patient safety committee, or your clinical audit committee, or indeed your executive management team. You will get hopefully the support and the buy-in and the assistance with perhaps the change that may be needed to move to that space.
thank you for that. And you know, are there things that we can do to help this? You know, I mean, when that is shared, you know, what are the things that we can do to help that information then to you know, really have an impact?
It's a great question, John, and I think certainly from, you know, my various posts throughout the HSE, be it particularly in the West and more recently 8 years here in corporate, but I would say one critical thing is it's about creating that space on an agenda, be it at the executive management team or indeed your local quality patient safety committee, having that space to bring clinical audit to the table. And that might be, we know these agendas are tight, there's lots of competing topics that need to go on the agendas. But even at hospital level and indeed regional level, if the space for clinical can be put in there, and if, you know, even at a minimum quarterly, so that there is the awareness of the wonderful clinical audit activity that's taken place, both at national level and indeed local level, that builds momentum, but it will also build the whole ethos and drive that culture change that is there. But, and I think, you know, it just brings everybody together. And going back to Colm's earlier point, that is demonstrating both locally as individual practitioners and collectively that you're proactive in that space, and that you're not waiting to be reactive to the, you know, to the next crisis or indeed the latest crisis. Because, you know, that is the space we all work in healthcare internationally. So clinical audit, going back to the power of it as a tool, it's a simple tool, but it sure is very effective when used properly.
Super. Thanks, Karen. And Conor, just to ask you about some of the data from your part of the audit, the survey. You know, there's some very high numbers there. You know, 80% of respondents saying that audit information led to improvements. I think again 93% said the data was used for quality improvement. But you know, where there is a gap, you know, how do we use that? And again, you know, can we get more out of that? Even if people are using it, can we make it that they get more from that information that audit is giving them to inform quality improvement?
Thanks, John. First, I'd just like to acknowledge my colleague Aisling Connolly in NOCA. Karen mentioned who put all this together, but she was responsible for nearly all of the work putting this together. So Aisling is listening in. Thank you very much, Aisling. Yes, as you say, what we have recognized in the past is a significant gap, and it was borne out in the local survey. We didn't ask the question in the national survey about the step 6, transferring data into action. So first of all is to recognize there's an issue, and that's for everybody to consider. Everybody who's involved in audit, are they actually focusing on improvement step 6? It's very challenging. I know, for example, in the medical sphere, I'd be interested to hear what Dr. Byrne says, but in the medical sphere, it's very challenging. NCHDs move through in a 6-month rotation. It's difficult to have them involved in improvement, and yet they're all obliged to do an audit. So it's clear that with a little bit of structure, for example, NCHDs in a service can be doing improvement. And a point I made earlier when I was speaking, I do think it's important for the senior people on a team to ask, what are we doing for assurance and what are we doing for improvement? Because at a certain point, you will reasonably say, the data shows this service is as good as it can be, you know? And again, this is another interesting one, John, we could discuss. You know, are we seeking perfection, or are we seeking a high quality service, knowing that there are always going to be errors and mistakes? So even in my own specialty of pathology, we only get things right 99.5% of the time, and we work in a very controlled environment. But we tell everybody our national program shows a 0.5% error rate. So that, I think that perfection is not possible, but assuring that it's as good as it can be is. And again, when people are talking about trying to find time, another tip perhaps is that you don't have to keep doing the same audit all the time. If a process is in control, and you learn about that in your basic QI training, if the process is in control, then you don't have to audit it so often. Many of us are stuck in a reverberating circuit of doing the same audit again and again. Use that time to do a new audit and improve something else. As Karen said correctly, we need to have QI on the agenda of every committee meeting, and perhaps another way to find space for that is to take AOB off it. There's a PDSA for you all. Take AOB off the agenda and put QI on instead. And then maybe the next step is to have somebody with QI training to lead the QI space at that meeting. And it's universally applicable to a unit meeting, to the executive management meeting, all of those places that can be done. There's a starter for 4 anyway.
That's fantastic, Conor. Thank you so much. Loads of ideas there for us to dwell on. I'm going to go over to Edel now, because again the theme of the Audit Awareness Week is local focus and global impact, and I think Edel, you work with NPEC, and I suppose I looking for examples of that, local focus and global impact, and where, in audit we talk about closing the loop, learning kind of locally and then turning that into an improvement project. Have you any examples of where audit has led to that action, and from your own work in NPEC?
Yeah. Well, for those who are listening today and are not aware of NPEC, we conduct a suite of 5 national audits of the maternity services, which have informed the development of practice guidelines, policy, healthcare policy, and also quality improvement initiative, which is a major fundamental aim of our audits. And one example is what we call the Postpartum Quality Improvement Initiative, which is a PPH Quality Improvement Initiative. For those who are not aware, this is obstetric hemorrhage occurring after delivery. And what highlighted the need for this quality improvement initiative was our audit on severe maternal morbidity, which highlighted increasing rates of obstetric hemorrhage. And not only that there was a huge variation between units in obstetric hemorrhage. So a big question was it practice difference? Was it how people measure blood? And this particular quality improvement initiative has been implemented nationally. It's a collaboration with the National Women and Infants Health Programme. And it standardises approach through unit-led projects. And I think that is key. It's unit-led, and in implementing toolkits in the evaluation of blood loss, standardising management of care of women experiencing hemorrhage, and also the review of major obstetric hemorrhage events. Again, documentation during an event varied across units. So an example of how audit at national level can filter down into units to improve care.
Thank you. That's such a great example.
Also, another example, I think, of an improving, I suppose, in guiding care is that our audits have contributed to a body of evidence. And one such audit data is the evaluation of very low birth weight babies. And this informed the development of a guideline on the perinatal management of extreme preterm birth at the threshold of viability. So this document has recommended a change in practice, and the threshold of fetal viability has gone from 24 weeks to 23 weeks. Right.
So there's some really concrete examples of where audit has turned into action, and again, I think the importance of for the QI people, look for the variation, I think, and go after the variation is what Deming used to say. That's where the learning is. So thanks for those examples, Angela, or Edel. Thank you. Angela, over to you. Angela, you've a role. You work as a paediatric radiologist. You've a role with the National Specialty Improvement Programme, but you also obviously work locally in your own centre in Crumlin. Would you maybe tell us a little bit your experience in establishing a local audit group and what you've learned from doing that?
Thanks, John, and good afternoon, everyone. I work in CHI, which is a very exciting time, obviously, with the new Children's Hospital. But obviously, there's challenges as well, because we have to try and align policies and procedures across both sites. And we have an excellent clinical audit group. But we thought that maybe locally in our radiology department, it would be nice to look at areas where we could possibly improve or find things that need an improvement across both sites. So we decided to have a focused local radiology audit group. And the first thing is we wanted to be multidisciplinary. So there's no point in having all doctors or all nurses. We want a representation from nursing, radiography, our physicists, from admin staff, and from physicians as well, so that there'd be diversity in the group. And that's great, really, because when everybody sits down in a room, there's lots of ideas of, I mightn't realize there's an issue with the admin staff, they may not realize there's an issue with the nursing staff, but when we all come together, we can come up with a lot of ideas for audit. So we wanted to bring those ideas back, so then I'd have some topics that I could share with my radiology colleagues and with the NCHDs, and similarly the same with nursing. So as well as identifying topics for audit, we also wanted to collate what we have already and have somewhere for them to go. So make sure every audit we did was registered. And we also came up with this quality improvement board in the department. So putting up audits that are happening at the moment for everyone to see, so patients can come in and see what's going on in the department as well. One area that, one audit that actually, I mean, what we wanted to do is not just look at problems, but try and solve them as well. And we had a very nice audit led by nursing, and it was on nurse-led sedation. There were slightly different practices across both sites. One site sedated slightly older children, and their failure rate was maybe a little bit higher because of that. But the other site had a much longer GA wait list. One site used intravenous cannulas more than the other. So we wanted to bring the policies together, because obviously we're going to be all working together, hopefully in a very short time. But we decided that we needed essential people to help us change the protocols. And these essential people would be pharmacy to help us maybe slightly change the chloral hydrate dose, and also anesthesia to make sure they were on board. So very early in the process, we all sat down together and discuss the best way of actually coming up with a new sedation policy. And that's what happened. Both sites were audited, and now with the help of anesthesia and pharmacy, the sedation age is 3 years old. We hardly have had any failures. The children no longer need IV cannulas because anesthesia are happy with the younger kids, and the pharmacy are happy with the dose. So it really did bring audit into practice, and I think everybody now is happy with the new policy.
Thank you so much there. Again, really great examples of turning, you know, audits into concrete change. And again, I'm really struck by the need for interdisciplinary and interprofessional working here. That again, I think audits focusing, you know, really on things that are important to patients are able to show up. I'm going to go to Juanita just to see if our audience have any questions for the panel and anything that they'd like to share with us or comments. Juanita.
Thanks very much, John. And talking about patient involvement is actually a really good sort of segue, because there is a question here about including the International Consortium for Healthcare Outcome Measurements sets within QI, as they include direct patient views. So I'm just wondering, from panel perspective, at the moment, are there any existing audits including direct patient opinions or views or feedback that you might be aware of, or is there any guidance on same? And maybe we might just start maybe with Karen and then go to Conor and Edel, if that's okay.
Thanks, yeah, thanks, Juanita. So currently, and Conor can certainly jump in here, all of our portfolio of national clinical audits that's taken place, they all have at least one, if not two, patient representatives as part of that. It's certainly, we're seeing the pendulum, you know, move in towards of, you know, if we were having this conversation perhaps 15, 20 years ago,
it would be different.
Minimal patient involvement. So I think it's a much more, it's a growing space, but certainly there's a lot more room for improvement. I think it's fair to say everybody on the call would agree that, you know, heretofore there's perhaps a little bit of reluctance is the wrong word, but hesitancy, and it's almost driven by fear, I would say. So I think, you know, in the spirit that we've seen, you know, with all of the fabulous input with patient representatives now, you know, sitting pretty much on all committees at health level, which is great. So I think, you know, we are seeing it move in the other direction, but there is room for improvement. So I would say absolutely don't hesitate. You know, certainly bring your patient partner on board, because, you know, you've just got that wealth of information that they will bring to the planning of the audit, and indeed at all stages. And very often they will ask the question that perhaps other people are pretty much maybe a little bit hesitant of asking. So it's certainly a great experience to bring your patient in as early as possible in the audit site.
Thanks very much, Karen. Conor, anything to add to that?
I agree with everything Karen says. Just to emphasize, the NOCA audits, as you know, have detailed patient input and have highlighted that. But as you say, it's been an improvement exercise for us over the past few years. Now it's highlighted. Also, PPIs, as Karen said, patient and public representatives sometimes aren't quite sure of what their role is at a committee like this. What I have done at a couple of meetings in the past is to put a formal slot for PPIs on the agenda. So I'm adding to your agendas, but I've taken AOB out. But I'm sure you can also take out minutes and matters arising, because I find that you circulate minutes beforehand. This is a PDSA for you all to try. And if anyone has issues, they can contact the chair. and then you don't spend 10 minutes talking about who said what to whom before the meeting gets started. Instead, you can get straight to the QI person. So to make space for that, having done that, you now have space for the PPI rep or reps on your committee to bring whatever they want onto the agenda. And I think that's, again, at least we've only just started it, but I would hope that it will be empowering for those representatives, particularly those that are quite experienced. To the question about patient outcomes, I think that's a very challenging one and a great question. I don't know if many of our clinical care pathways are mature enough to be looking only at outcomes at the moment. I think we're at the data gathering stage and we're looking at process. We're doing data, process, outcomes. I think that where we have excellent data and where you're confident that your processes are robust, then you can start looking at outcomes. And again, maybe patients are happy to feed that back. Most of us healthcare professionals are concerned about our processes still in most areas and are a little loath to move straight to outcomes. But absolutely, patient-reported outcomes is the ultimate test of what we do, and that should be where we're aiming for. And we're talking about that in NOCA, and we certainly have it on our agenda. But I could say that there's no audit that's confident to move to patient-reported outcomes as its sole output, even with audits that are mature in NOCA. Thank you.
Yeah. That's it. Thank you very much. And it is that whole cycle really of the process, and it's the end game and where you want to get to, but we're not, as you said, just there just yet. And just, you know, in terms of Edel, from your perspective, from that patient involvement piece.
We similarly, all our audits have a patient involvement, and their overall governance of NPEC, there's patient involvement. And it's actually been very useful. I agree with everything that Conor has said. And they bring a different perspective. And what we have found is that they would very much want, from the maternity services point of view, more education, public health information, you know, and that is something that they feed very strongly back with, because again, a lot of women, you know, it's a normal event in most women's lives in the continuum of life, and a lot of them find that the public are not aware of a lot of outcomes, so they really push for that. We have a lay summary with all our reports that it's written by the public representative, and we have a training day for them, again, as Conor said, what exactly their role is. So that has been very useful on that.
Thank you very much. And we might just come very briefly to Angela, because I'm conscious there are a number of questions in the chat about templates, and Karen is actually going to take us through a number of those in a moment. But before we do that, Angela, you'd spoken about bringing that group together. And one of the challenges obviously now is that people are under pressure within services. So have you any magic secret for bringing a group together to talk about audit, in case there's anyone listening and wanting to do the same within their service?
Yeah, it's surprising when you actually look. I mean, most people are quite enthusiastic about trying to change things, trying to make things better. And all you need really is one or two people who are interested to get it going. So, I mean, for us, it was actually the physicist came to me and was asking me about, you know, process across both sites, and then we started talking. So I think communication is really the big thing. You know, talk to people, get people involved. You don't have to be having meetings every week. You know, everybody has lots, you know, to do. And I think, you know, having meetings for the sake of it doesn't work. So even if you plan a meeting every, you know, quarterly, every 6 months to get together for an hour, I think people can make that time. So it's just, you know, continue enthusiasm and try and engage people as much as possible, and show when things are being done well. As I said, a quality board that will show that yes, you know, things are working, I think, can get more people on board as well.
That's fantastic. And I think Conor touched on that 80% of waste. A lot of what we do is waste, but I think that efficiencies around meetings would make all our lives a lot easier. So there's something to be said from a learning perspective there, totally unrelated to clinical audit. But what I will do is I'm going to pass back over to John and Karen. And as I said, there's a few questions there around Gantt charts or templates that might be available for creating a hospital-wide plan. And Karen is going to talk about the available resources to maybe support you in that space. So thanks very much.
Yeah.
Thanks, Juanita. And we'll bring back up the slides there, Chris, because I think Karen is going to just walk us through some of the resources that are available. We put a link in the chat there to ICHOM, and I put a link into What Matters to You as well. Just, you know, great question. And I think ICHOM is a great way of looking these patient-reported outcome measures and patient-reported experience measures. you know, of course, the thing that matters is what you measure, you know, so often. And these are, I suppose, maybe examples of the most important measures that are out there. So I'd encourage people to check them out. And Karen, you're going to share with us some of the resources that are available to people through NCC and through NQPS for improving our application of clinical audit.
Thank you, John, and great. And just scanning some of the feedback there on the chat box, and we will obviously get a chance to look at it in greater detail after. So there's lots of really good suggestions coming in. So we love to get that feedback. So there's a lot of things there. We'll go into the planning pipeline. So for those not familiar with our current suite of resources and guidance from a clinical audit perspective, we have a growing suite of resources which are well tried and tested in the best spirit. So perhaps the most widely used one currently is, for those not familiar of it, is our nomenclature, which is a high-level glossary of terms for clinical audit. So it contains, it's a very small document, only 7 pages in fact, but it is really, really powerful. So it's got 14 definitions, and it goes through that classic question is, what is the difference between clinical audit, QI, research, service evaluation? So anyone today or tomorrow sitting down to plan their audit, it is one of the most fundamental important questions that you ask yourself in the planning. So to keep people focused and to keep them safe in terms of practicing standards that are in line with our best international practice, do have a look at our glossary of terms. So all of this information is available on our website, and for those that have your phones there, you can either scan the QR code as well. We've also revised our practical guide to clinical audit. So lots of you I know are early adopters of clinical audit, and you will be familiar with the previous publication. So this is the more up-to-date guidance document, and we've kept it as simple and as practical as possible, hence the name. So it follows very clearly, and the little icon is there at the top right of the screen. The 7 stages of the clinical audit cycle, the actual document itself is color-coded, so that people, if you're just interested in QI or you're just interested in the methodology piece, you go to the relevant section. So there's lots of practical templates, and sometimes we feel we're getting template-itis around NCCA, but people love the practicality of being able to download a tool, adapt it at local level, and then have it to use for real. So that led us to actually produce what is known now as the Local Clinical Audit Toolkit. So that contains a suite of resources that is suitable to use at local level. So it ranges in no particular way from, for example, a terms of reference template for your local clinical audit group or committee. And it has got a range then of practical templates, such as designing a questionnaire, collating a local action plan, and so on. And just there recently, in the spirit of moving to, I suppose, sometimes the subject matter that people find perhaps difficult to talk about, it's the whole piece of keeping us safe while practicing clinical audit. So that is why it is very important to have up-to-date awareness of data protection, GDPR, and now moving to the Patient Safety Act. So we've produced an FAQ document, again, asking those questions and indeed providing the answers on safe practice under the umbrella of legislative changes. And as I said, all of the resources are there to download, and we do have a small stock of hard copies, but again, in the modern day, people much prefer to be able to download their own copy and share it electronically. Lots of you here today will have been through our education and training programs over the last 2 years and growing, and we're delighted to say that we've had up to 2,000 HSE staff through 1, if not 2 of our programs over the last 24 months. So again, we listen to your feedback, and certainly that virtual space suits people, just like today's events where people can come together. So it ranges from our e-learning program and our fundamentals, and indeed our advanced clinical audit training. And we've also recently moved to what we call our clinical audit action hour, which is very much like a lunch and learn. So again, the whole prospectus is available there to download via the QR code, or go to our website. And again, just to mention that all of our training courses under the umbrella of clinical audit are eligible for CPD and CEU points. So do check them out or contact us. We have a little mailing list, so do join up. We'd be delighted to have you on board. And then last but not least, because I'm conscious I don't want to steal other people's time, is connecting with us. So again, you'll find us there on LinkedIn. You will also find us on X, formerly Twitter. And again, just to scan the code for our example. And indeed, we are also on email at ncca@hse. So do keep in touch, and we look forward to meeting you at a future event or indeed our upcoming training. Thank you.
Thanks, Karen. And yeah, we put some of those links in the chat as well there and encourage people to check them out. And now finally, just as we finish up, I'm going to just hand over for a moment to Teresa Donnelly, who has just created our latest episode of Walk and Talk Improvement. And Teresa's going to give us a short preview of the podcast that she's created with her colleague, Selena Daly. And Teresa, it's a pleasure to welcome you. Thank you for joining us. What can we expect to hear on the podcast?
Thanks so much, and good afternoon, everybody. I'm delighted to be here, and I've certainly enjoyed that session. Clinical audit is something I would have dreaded in the past, and I've always mixed it up with research. It's actually a very simple and lovely tool to improve patient care, and I suppose that's basically what the podcast is about. And it talked about a clinical incident that I was involved in, and throughout my career I've been very fortunate in that I've always worked with people who have always wanted to do the right thing. We've always wanted to give our patients the very best. However, error happens, mistakes happen, and I was one of those people that was involved in an error. And I suppose I talk about how following on from that, I went on to do a little bit of education where I got the bug for clinical audit. And I undertook an audit, and as a result of that, from the clinical incident, we improved patient care. And I think that's exactly what this whole talk has been about today, is about improving patient care and how we close off that cycle. So from that then, I would have carried out loads of audits and seen the benefits from doing the audits. Very lucky that we have the centre. It's such a huge support. I know I certainly have dipped into the centre for support. So I'm delighted to say that I'm now currently the director of the Centre for Nursing and Midwifery Education in Sligo, Leitrim, West Cavan, and I very actively teach clinical audit because I see such a huge benefit. And actually this morning we actually have a session ongoing in the centre. So that's just an overview of I suppose what the podcast is about how we use clinical audit to improve patient care, and it was as a result of a clinical incident.
Thanks, Teresa. That's wonderful. And the QR code is there, but people can find this on the Walk and Talk Improvement podcast. And I look forward to listening to that one soon. So well done, and well done to Selena. And thank you.
Thank you, everybody.
Okay, well, I think that's all we have for today, folks. Thank you. I want to thank our panel for being so generous in their time and setting up the session, and it takes a lot of work to put all these sessions together. So again, to thank Juanita and Shima and all the people in the background who you don't get to see, who do all the really hard work here. That is the end of QPS Talk Time for this season. We're going to take a summer break, and if you miss us very much, you can check out on the YouTube channel and watch some of the episodes that you missed. And we've had lots of really great speakers this season. So I'd encourage people to check out, and really from a very diverse set of speakers. And then hopefully we will be seeing you back in September, and you'll be hearing from us soon as to our September date for coming back to you. And that's all from us then today, and thank you very much, and we'll see you in the autumn.